I heartily welcome one and all for this recent update in COVID-19 virtual program. All delegates who have joined virtually from whichever place to learn from the esteemed faculty. On this occasion, I welcome our guest of honor, Dr. B.S. Shankar, Professor Emeritus RGHS Bangalore. I also welcome Dr. Shivraj Alshetty, President Mesat, and Dr. Murugesh Pastapur and his team. I welcome our guest of honor, Dr. Rajesh Upadhyaya, a BC Roy awardee, Dean ICP, and past President of API, Director of Gastroenterology, Department of Max Super Specialty Hospital, New Delhi. I also welcome our guest of honor and Chief Moderator, past Governor ACP India Chapter, and past President of API and Dean ICP, who has held several posts in the past, a great personality in field of medicine, loved by all over the country, nationally and internationally, highly academic and an innovative personality. I invite our guest speaker, Dr. Raman Ganga Khedkar, National Chair ICMR Delhi, former Head Division of Epidemiology and Communicable Diseases ICMR, a Padma Shri awardee in 2020. He has held many positions in ICMR, WHO, UNICEF, and Director in charge of NARI Pune. I also welcome our own AIG family, Dr. D. Nageshwara Reddy, Chairman and Chief of Gastroenterology, AIG Hospitals, Hyderabad, recipient of BC Roy, Padma Shri, and Padma Bhushan Award, and received other innumerable awards, both national and international, like Secretary General of World Endoscopy Organization, and is the first Indian to receive Fellow Award from American Association for the Advancement of Science in 2020. A great scientist, scholar, trainer, master teacher, and teacher of teacher, and a good human. I also invite our panelist, Dr. N.K. Singh from Jharkhand, a core academician. He has his own WhatsApp CME India founder admin, doing a great job by updating everybody in the national platform. I also invite Dr. G.B. Sattur, our own state panelist from Hubli. He is an expert committee of our state COVID-19, a BC Roy and a Rajyotsava awardee. In this COVID-19 pandemic era, on this occasion, I salute the COVID-19 healthcare workers for rendering their untired services to COVID-19 patients in spite of so many hurdles. Let us not waste their time by reading their CV profile, which runs in pages. Let us utilize time by hearing and exchange of knowledge with them.
Thank you. Thank you very much. At the outset, I'd like to thank Busat for this kind invitation, especially my friends Sangram, Shivraj Alshetty, and Murugesh. They've always been there. I'm also honored to have Muruganathan coordinate the whole. He's been so active academically in many of these areas. And of course, Rajesh Upadhyaya, a colleague of mine in gastroenterology. So it's a great pleasure to have all of you here. We just had a fantastic talk by Dr. Raman, who is, of course, an authority in this area. And we see him so frequently on the television screen too. So he gave us a very nice evidence-based talk on all the drugs that have been used in COVID and where we are going wrong. Now, you may ask me, how is it that I, a gastroenterologist, am involved in this? The reason I'm involved is that I happen to chair a hospital which has got a group of very highly qualified internal medicine people, pulmonologists, interventionists, infectious disease specialists, and of course, gastro-cardiologists and all together. When COVID first struck us, this group of people, about 56 of them got together and decided to make so-called COVID protocols and guidelines. Every week, they would look at the literature that's coming in, critically study it in a graded form, see what information is right or wrong, look at grade based on RCTs, meta-analysis and so on, and come to certain conclusions. And just about a few weeks back, we finished a series of COVID protocol guidelines, which is available in YouTube and is now being published as a book, which is also will be available in our website. So this was my attachment with this, and having attended all this and been there and been involved with this group who've been treating these patients, about 20,000 patients have been treated in our hospital. And I think with the mortality rates, which are slightly lower than the national average. So we decided to bring all this wisdom together to have this guidelines and come out with this. There are many guidelines available in the literature. There are guidelines which are usually Indian, like the ICMR guidelines, the Ministry of Health guidelines, the AIMS guidelines. There are also guidelines which have come from different national agencies, the Mayo Clinic guidelines. The most respected or the most followed one is the NIH guidelines, the National Institute of Health guidelines. The NIH guidelines are one which is some basis in which I'm going to. The reason why it's important to follow only one guideline or one protocol is there's a lot of confusion among literature. And I think Raman has given a brilliant lecture on how so many ifs and buts and so many contradictory statements are there. So if you start following all this, you'll start getting confused. So for a practicing physician, what does he want? He wants to have a clear-cut idea of what to do in his patient. And what I'm going to do over the next few minutes is try and give a clear-cut idea, avoiding many of the controversies. And I'm going to show you what is the AAG COVID management algorithms that we developed and how we have been very successful in treating these patients. I'm going to first start with two slides, which are the most important ones. I'll come to those two slides. You listen to these two slides, they're enough. You don't have to go through others. We're going to start about the initial management strategy, briefly about many of the pharmacotherapies which Raman has dealt with, how to prevent complications, and to summarize briefly. But first, before, you have to understand that there are various diagnostic components of how we're testing. Suddenly, into our diagnostic armamentarium has come IL-6, D-dimers, ferritin, and so on. We're not doing this earlier. But now when you start doing this, that even in viral fevers, very often we find an IL-6 elevated. So my colleagues sometimes come up with reports somewhere else done saying he has COVID because IL-6 is elevated. This is wrong. These are non-specific. They don't have anything to do with COVID. We just got awareness of this because we're doing it more. Now, the most important, of course, is RT-PCR, and it's important to be aware there are several fallacies in this test. 70% positivity even the standard RT-PCR, 50% is rapid test. But one important thing is that this variation occurs not only because of labs, but because of how the swab is taken. And we have recently published a large study to show that in those who are RT-PCR negative, if you add sputum, your chance of positivity increases to 90%. So my suggestion to the practitioners is, if you are repeatedly getting RT-PCR negative 1, 2, 3 times, the third time kindly don't do only RT-PCR in a suspected case, but add sputum in the same sample as the patient, and you'll find that your positivity goes up to more than 90%. This is just a practical point I want to tell you about. Now, understanding the components of treatment, we have gone through all of this, and I think a lot of literature is against so many medications. So let's briefly look at, as I said, these are the two important, next two slides are the two important ones, very simple ones, which will, I think for the practitioners, very important because you'll really understand how these patients should be treated and what is the mistake we're making in treating these patients. The important thing to understand is that this COVID disease has a biphasic phenomena. The first week or 10 days is a viremic phase. The second, from 10 days onwards, it's a cytokine phase. So whatever treatments we give in the first 1 week or 10 days should be against the virus. So if you're giving remdesivir or any antiviral drug, it should be against the virus. You should not use corticosteroids in this phase because you'll increase the viremia. The second phase is cytokine phase, where the most of the damage is because of increased cytokine. It's an immunological phenomena. So in this case, antivirals like remdesivir will not work. At this stage, only steroids are going to work, and that's a famous recovery study we'll come to a little later. So in this phase, we should not give mostly not depend on antivirals, but depend on immunosuppressions like steroids. So this is very important. And basically, we have only two drugs, antiviral and immunosuppressants, only 2 weeks. One should be used in the first week, one should be used. Very simple. Now, in fact, we have again published this very important study in MetaGene, where we've shown that in Indian patients, why the severity is not so much. The incidence is high, but severity, mortality rates are much less than Brazil, America, and so on, is because the virus enters into the body using an enzyme called TMP-RSS2. We have shown that in Indian subjects, the TMP-RSS2 is actually mutated, so it doesn't help the virus so much. And there's some very interesting discussion coming on that. We'll come later to that. But the second important slide I wanted to show you, this is a slide that all practitioners should sort of mug it up, because it's very important. Now, the COVID stages, because the whole treatment depends on that, mild, moderate, severe. There are various ways of defining it. ICMR is given different definitions. Ministry of Health is given different definitions. The AIMS is given different definitions. And for our purpose and what we follow in our institute, and to make it very simplified, I'm going to discuss this NIH guidelines that have come. NIH guidelines basically divide COVID clinical features into 3 stages: mild, moderate, severe, right? Mild is fever, uncomplicated. These patients have mild cough, upper respiratory tract infection without dyspnea or hypoxemia. Very simple. Majority of patients fall into this. Moderate are those who have lower respiratory tract infection, usually lung infiltration with pneumonias and so on. The respiratory rate increases and oxygen saturation is still maintained. Here the confusion comes because in some of the local guidelines they give oxygen saturation less than 94, but this NIH very clearly saying that oxygen saturation is still maintained. So moderate cases are those who have a lower respiratory tract infection. Usually they'll have more cough, deep cough, and they'll have, if you take an X-ray chest, you can see a pneumonic patch. Severe infections are the last category, who have a lung infection which is more than 50%, their respiratory rate is more than 30%, and their oxygen level starts to fall, less than 94. So this is the classic NIH guidelines, and kindly remember this because all your treatment depends on this. Now to this, we have added 2 other categories. The critical ones. The critical stage is when these patients develop ARDS, septic shock, multi-organ dysfunction, and oxygen saturation is below 90. Most of them come to us below 70 and so on. These are the critical patients. These patients, I'm not going to discuss in detail because they're going into ICU for ventilation. They require a variety of different types of intensive care treatment. But other spectrum is asymptomatic individuals who are becoming very important now because these are the ones who are transmitting the infections to us. They don't have any symptoms. And we're seeing more and more of these cases, especially those who are getting partially treated. So asymptomatic and of course before the infection, pre-symptomatic. So these are the categories. But remember, for a practicing clinician anywhere in the periphery, these 3 mild, moderate, severe category, keep this in your mind because this is going to tell us how we're going to treat. And if you look at how in clinical practice, more than 90% of the patients fall in this category, below this category, 90%. So you don't have to do anything for them. You don't have to do. That's why many so-called RMP doctors or Ayurvedic doctors are successful because you don't have to do anything. Patients are getting better. They get credit for this. It's only the 8% of the patients who actually develop this more moderate severe case, and 2% go into critical stage. And the average mortality is 1 to 1.1% in our country, maybe around less than that in our institute. So this slide I hope is clear to everybody. So these 2 slides which I showed you will set the stage for how we treat the patient and will understand very clearly what we should do in clinical practice. So let me concentrate a little on mild cases because 90% are mild cases and you don't do anything for this patient. It's very difficult not to do anything for the patient because they go on, ring up, they'll come and say, I have this. They've got a lot of anxiety, phobia. So we have a grading system also. The clinical score should not exceed 8 in these patients when you call them mild. They have fever which is mild, not exceeding 100, occasional cough, no breathing trouble, no major fatigue, no diarrhea, and oxygen saturation is always above 95. So I sometimes ask our patients to keep a diary or a chart with them and just note down this and tell next 3 days you tell me what is the temperature, what is the cough pattern, is there any breathing trouble, is there any major fatigue and so on. So they'll tell us and you can actually do a mental scoring or say that. So then you know it's a mild case. So what do you do in a mild case? 90% are mild case, right? So in a mild case, we'll ask the patient to take paracetamol every 8 hours for the fever so that he feels better. Even this is not necessary, but they feel better, body pains come down. So regarding vitamin C and vitamin D, somebody is interrupting. Or somebody is, I think I have to switch off their mic because I'm able to hear their mic. Can I go ahead? Okay, yeah.
Yes, so, yes, sir. Good, please go.
So, vitamin C and vitamin D, of course, there's no evidence suggests it's useful. But as a practical physician, I can tell you what, patient requires something. You say nothing to be done, just take paracetamol, be in your house, they're not very happy. So something has to be given. There's no harm in giving C and D. There is some weak evidence against D that if you have a vitamin D deficiency, disease seems to be more. So, okay, give it once in a week for 2 or 3 weeks and you can stop it. So, this is general symptomatic treatment. As I said, as a practicing physician, this is very practical. Patients feel happy. And now that there is something against the zinc, maybe you can avoid that. but at least vitamin C, vitamin D, there should not be any problem. So you give this, and then you follow up the patient for 3 days. So 3 days critical. Mild case, only paracetamol, follow for 3 days. If in 3 days the symptoms are improving, then nothing to be done. Just leave the patient alone. Maybe he may require paracetamol for another few days just for this body pains and fever, right? So we continue monitoring the patient for 10 days. Earlier it was 15 days and now it's 10 days. 10 days time, you say that he's all right. He can now go back to his work and so on. We need not repeat the RT-PCR after 10 days because there is no evidence that doing RT-PCR after 10 days will help us in other ways. So now the recommendation is not to repeat it. But look at the other patient. Symptoms are not improving. His CRP is going up and the CBC also showing a neutrophil lymphocyte ratio. So if lymphocytes are going below 20%, certainly below 15%, you have to be very careful. Because these patients are going to develop into problems. So if you have a CBP, a lymphocyte neutrophil ratio or a CBP between 5 to 15, patient is continuing to have cough. The only evidence we have in literature which is accumulating is to give inhaled budesonide 400 to 800 micrograms twice a day. So this is the only thing we give. And if they're improving, then of course we continue monitoring these patients. We monitor for budesonide on 3 days and slowly taper it off. So for mild cases, this is the only evidence-based treatment. There is no evidence that other drugs are going to be useful. Just remember this, very simple. No treatment, maximum if they have cough with increasing CRP, give budesonide as an inhaler. But if during this monitoring of these 5 days, if the patient's saturation drops to below 94, this is a red flag. So ask the patient to keep a pulse oximeter, and pulse oximeter, there are variety available in the market. Be careful. Select a one. Some of these cheaper ones are not very good. So select one which you are confident and use this. So just to summarize, no investigation, symptomatic treatment, and there may be a role of inhaled budesonide. So again, now what about monoclonal antibodies? I just wanted to get this to you. Monoclonal antibodies. You can see here I put as query monoclonal antibodies here because there is some evidence that certain category of patients who can go from mild to moderate to severe, we can prevent monoclonal antibodies. How effective this is, we are still studying now. But I think this is very important information. Again, physicians should know because monoclonal antibodies are now available. Cost is not a factor because people going to severe disease, they're spending 60,000 to 1 lakh rupees per day. If you can prevent that and give one shot of monoclonal antibodies, why not if it's properly indicated? So there's a lot of interest from I think a lot of people. So monoclonal antibodies now currently, these ones are available for last about 10 days in our country. We've been using this. This is from Roche company marketed by Cipla. The indications are more than 65 years, BMI more than 35, uncontrolled type 2 diabetes, chronic kidney disease, immunosuppression, or even those above 55 years if they have CAD, hypertension, or COPD. And even younger patients, BMI. So obesity is a major indication. So if you have an elderly patient, obese, uncontrolled diabetes, there's a strong indication for using monoclonal antibodies. You have to use half the vial. So for 2 patients, you can use 1 vial, half the vial. And very easy to give, half an hour, you give it and the patient, given as outpatient. The question here is, it's so dramatic, you can predict which patients are going to severe disease. Now we have a list of all these conditions. So why not give it all the cases? The only problem is regarding how effective this is against our mutant strain. We now know the mutant strain that we have, the B1617, 1 or 2, how effective, we still don't know. We are studying it. In fact, we have now launched a major study in our institute where we're studying the efficacy of monoclonal antibodies, both in clinical situation and in lab to see how effective it is. We'll get an answer in 3 to 4 weeks. We'll let you know that at that time, then we can be more aggressive about using monoclonal antibodies. So this is the information, latest information about monoclonal antibodies. What about convalescent plasma? Again, I think did very well with Raman. We are starting to use it less. Lot of confusion because it's been used wrongly. If we use convalescent plasma, it should be used properly. High antibody levels have to be detected. It has to be used within 1 week, not later than that, and so many other situations. So tending to use it less. Although my own opinion is, that there may be a small role, a small window period, especially if we don't have monoclonal antibodies available, same indication as monoclonal antibodies for convalescent plasma, but collect it properly, check the antibody levels, they should be high level, because then you're giving a polyclonal antibody to this patient, may be useful. That's what been our impression before monoclonal came in. Okay, that is about convalescent plasma. So you see, management of mild disease, to summarize, no routine blood investigation, essentially symptomatic improvement. Kindly don't go for all this ivermectin, zinc, so many other antivirals have come, not proven. They're producing a lot of side effects. Only inhaled budesonide, very role, no role for antibiotics. Every patient, unfortunately, when we see them, they come to us, is put on doxycycline for some reason. It put on azithromycin for some reason. Absolutely no role. These should be used only when there's secondary infection. Most important, monitoring. Clinical monitoring, symptomatic monitoring, pulse oximeter monitoring. These two things which can be done in the patient's house. So I just put down a chart. You can later look at it. What are the must-dos in these patients? And of course, ivermectin, a lot of controversy. ICMR has advocated at one stage. I personally feel no role. Supplements also a lot of this thing. Vitamin C, vitamin D, maybe you can use because patients want it, but others don't. Okay. So now we shift from mild cases. We are very sure how to treat them. So we know how to define mild case. We know how to treat it. Now we go to the moderate cases. Moderate cases, you monitor mild for 2 to 3 days. They don't respond. Fever is persisting with other clinical symptoms. At this stage, based on the clinical symptoms, you know that patient has pneumonia, lower respiratory symptoms. You can advise HRCT or other D-dimer and so on. At this stage, if severity of CT is more than 10 score or D-dimer is more than 0.5 micrograms, you know you're dealing with a moderately severe illness. And these patients, you better advise for hospitalization. So mild, no hospitalization, moderate, get into hospitalization. Especially if a moderate symptom patient has comorbidities like diabetes, hypertension, obesity, you don't even have to look at the other lab parameters. Directly, they go for hospitalization. And these patients, we are starting on remdesivir, 200 milligrams first day and 100 milligrams for next 4 days for 5 days. And enoxaparin in a row for about 40 milligrams, that is not the therapeutic doses. So here, again, I want to pause a little because I think Raman discussed about remdesivir, what happened, all the clinical trials and all. A little controversial, but we are advocating in our institute, and based upon the small RCT that's available in New England Journal, there's nothing negative against it. The side effects are very less. And we feel, in fact, we're publishing a large series of over 10,000 patients. We feel that remdesivir, at present, we cannot do a randomized control trial because the ethical committee is not giving it. Observational studies suggest that remdesivir may be useful in these patients, and therefore you can start. There's no harm in starting. But it's important to monitor these patients with routine and, of course, IL-6, ferritin, LDH, and D-dimers, and CRP. So this should be monitored. And these patients, if CRP is more than 20, we have to consider a combination of remdesivir with baricitinib. This is based on a recent Act 2 study that came in the New England Journal, where they showed that combining remdesivir with baricitinib. Now, baricitinib, for those who are not aware, is a JAK1 and JAK2 inhibitor. It decreases inflammation without the side effects of steroids. Mild side effects, but less than steroids. So it can be used more progressively. And fortunately for us, baricitinib, which was very costly, now the cost has come down because it's being in India. 4 milligrams dose is costing very less, 100 times what it used to cost earlier. So it can be used more often. Now, if the severity score of CT is less than 10, D-dimers are less than 5, you can still continue to monitor this patient, but in the hospital for a few days. So moderate patients, most of them require treatment, maybe with remdesivir and anticoagulants, but some group who are very mildly symptomatic, who have a CT severity of only 10, can still be considered to be monitored like mild cases. So just again for practicing physicians. Now we come to the more severe cases. Now, if the fever is persisting with other clinical symptoms, comorbidities are there, and now the patients become hypoxic, less than 94, sometimes less than 90. In these cases, of course, you can advise the standard markers, and CVT severity index is seen, but these are the severe illness patients. So moderate and severe, the difference is oxygen saturation according to the NIH classification. Now these patients, we start remdesivir, enoxaparin, and dexamethasone. Now, this is based on the famous recovery trial. Again, kindly start dexamethasone only in the second week, not in the first week. The biggest mistake in clinical practice, the biggest harm to patients in our country now is the starting of steroids immediately at the time of illness, that is first week itself. It's causing a lot of side effects, viremia, side effects, and dexamethasone 6 milligrams, not large doses. If you don't have dexamethasone, of course you can give prednisolone or methylprednisolone, hydroxyprednisolone. That's a different issue we can discuss. But usually these patients require supplemental oxygen. So when you give dexamethasone, it means that these patients are on supplemental oxygen. Maybe just 2 to 10 liters, but some of them require larger dose. But supplemental oxygen and dexamethasone go together. Kindly don't give dexamethasone patients just like that without supplemental oxygen. Very, very wrong mistake in clinical practice. I want to reemphasize that. All the senior physicians here, you kindly educate the GPs and other people treating out there. The dexamethasone should not be used in settings other than this. Only then we will benefit. Now, you repeatedly do your every 48 hours you're doing your parameters. If the CRP is going up in spite of this, then you can add a combination of baricitinib. So you can give remdesivir plus baricitinib in this situation. A combination can be given in these patients. Now, what about other drugs like tocilizumab? Again, very rarely used. We use the ROAD. So, in fact, in managing severe cases, we have so-called ROAD and TOAD. ROAD is remdesivir, main oxygen anticoagulants, DEXA, for severe cases. TOAD is when you have to have tocilizumab. I'll come to that indications account what NIH has given. Before that, remdesivir, I know there's a little controversy, but I am for it, and we can give for all moderate severe cases, especially if they're hypoxic. It had to be given within 7 to 10 days. Kindly don't start it after 10 days, again, not useful. So patient on a ventilator on 20th day, no point in starting remdesivir. If the patient is asymptomatic and having very high inflammatory markers, if IL-6 is 300 or something, I think there's a role for remdesivir. Unfortunately, it has not been studied in this context. And unfortunately, it's very difficult to do randomized control studies with remdesivir at this stage. So management of moderate severe cases, you can see, is very protocolized test, supportive, pharmacological therapy, and oxygen. So remember this when you're treating patients with moderate or severe cases. Now, for those who are having more than 60 years and those who are having all these comorbidities, you have to be much more careful because of observation. The poor prognostic markers are lymphopenia, which is very simple to do, which I found to be very elevated CRP. Just 2 tests in small clinical practice, lymphopenia, elevated CRP. If you have access to IL-6, you can do that. Elevated D-dimer and anticoagulation be linked together. Kindly remember, and that may not be always true. Just because you have a high D-dimer doesn't mean you have to give anticoagulation. There's some dissociation. Again, I don't want to go into too much discussion on this. Ferritin is another marker. Some of these patients have cardiac toxicity, even young people. So sometimes if they complain of little chest pain, kindly be very aggressive in getting troponin done. Again, I'm not going to discuss in details of systems what happens with cardiovascular or pulmonary or gastrointestinal, because I'm discussing in general. Chest X-ray at basal level when the patient is admitted, and CT scan, again, lot of controversy. Even in the recent press, there's been a lot of fight between certain section of radiologists and pulmonologists. Radiologists advocating this, pulmonologists saying no, you can develop problems like, for example, cancer and all. But I just want to put it in context here. CT scan is rarely needed unless pulmonary complications are needed. But in patients who have clinical suspicion, RT-PCR negative, sputum chance also negative, then you can get a CT scan or alternative diagnosis like tuberculosis. But when a complication like pulmonary embolism, so-called happy hypoxia, some of these patients, saturations are very low. They sometimes don't look like they're looking very hypoxic, but these are the cases who have a pulmonary microthromboembolism. CT scan is very important because that will change the management. And of course, in post-COVID fibrosis. In my opinion, again, those are hospitalized. There's no harm in doing a CT scan of the chest, mainly to identify the CT severity, because there's some indication that high CT severity of more than 15 may indicate that these patients have to be treated more vigorously. But anyway, controversy, but CT scan, most patients, maybe one time is enough. No need of constantly going on doing CT scans. But if there is a complication like suspected pulmonary microthromboembolism, kindly get a CT angio done. This is making a lot of difference, because then you have to step up and go to therapeutic anticoagulation in these patients. Now, corticosteroids, lot of controversies. In our institutes, we use as less corticosteroids as possible. We are against corticosteroids because, unfortunately, the recovery study gave a wrong impression that corticosteroids are panacea for these patients. Everybody first day corticosteroids. Don't do that. Corticosteroids only in the second week, and dexamethasone only 6 milligrams orally, not higher doses. And then there's no proven role in increasing steroids. Patient is not responding, increase DEXA to 12 milligrams. No, don't do that. There's no proven role. You have to monitor the side effects carefully, and steroids stop after 10 days or at the time of discharge. Don't continue steroids for a long period of time. Most of the side effects are because of steroids. Now, there may be some discussion on this, but I want to be very, very clear. And about tocilizumab, I already discussed. Again, we are using it very less, but again, very clear indications given by NIH. Recently hospitalized patient whose need for oxygen is increasing, then tocilizumab is indicated as a single dose, mostly, sometimes 2 doses. Tocilizumab, most of these people can develop secondary infections, so be careful about that, but that can be used now. Anticoagulation, there's several meta-analysis to show that more than 14% have some sort of venous thromboembolism. So routinely moderate or severe cases are, of course, those in ICU anticoagulations. Again, very important that oral anticoagulants are not so good. Low molecular weight heparin is better for several reasons. Not only it's a good anticoagulant, but also it has got an anti-inflammatory, anti-cytokine effect, so may be preferable. And of course, when you detect microthrombi, you give therapeutic doses. Normally, we use 40 milligrams enoxaparin, but you can double the dose as a therapeutic dose. And finally, this is something that the practitioner need not go into, but should know briefly what it is, because these are the terminologies that are used by intensivists. So when patient becomes critical definition I told you, usually oxygen saturation below 90, usually 70 like that, multi-organ failure, septic shock. In these patients require a full therapy with a variety of things. They start initially when they have oxygen need for more than 10 liters, they start with NIV, which is usually CPAP like this. Then they're increasingly using a high flow catheter or nasal catheter, which can give up to 40 to 60. In the first wave, we used a lot of this, and we found that oxygen need is more and more. And now we realize that when oxygen availability is less, you have to be careful about high flow nasal oxygen supplementation, although these machines cost only 3 lakhs, they're cheap. Beyond this, they go into ventilator, and ventilator, when they go into ventilator, only 50% of the patients come out of ventilator. But what we are now increasingly found is prone ventilation. So out of the 24 hours, if for 16 hours they're done prone ventilation, they seem to improve. Not very easy, but this is one. And of course, ultimately, extracorporeal membrane oxygenation in some patients. Again, I want to just introduce this terminology for people to know. Very few people, less than 10% who go into ECMO come out. It's more for those people who can go later on to lung transplant. But just to know this terminology for a practitioner, what all this means. So just to conclude, what there's disease severity, this is again for you just to recapitulate what I told you to remember in an algorithm form. Patient is non-hospitalized, mild to moderate, kindly don't do anything. Maybe the patient can afford monoclonal antibodies. We are studying the efficacy in our variants now. It costs about 60,000, so you can think of this in those patients who are indicated specifically, older age group, above BMI, above certain age and all. For a hospitalized patient, those who do not require oxygen, you can still follow them. Then maybe remdesivir, in our opinion, may be useful, again, controversy, but those who are hospitalized require oxygen. This is the group who require remdesivir, not responding, remdesivir, baricitinib, not responding, dexamethasone plus remdesivir, and ultimately the last drug is remdesivir. And those patients who are in ICU requiring ventilatory support, you have to use dexamethasone and maybe a small group dexamethasone. We require tocilizumab. And of course, those who are going to ECMO, very few survive. So this is just for you to easy. You see, so many drugs, and we ultimately come up with only 1 or 2 drugs in this patient. So for those like me who are not so sharp, it's very easy to remember this, to treat our patients. Now, just a short thing on this long COVID or post-COVID syndrome, it's coming up. My belief is that for all the general physicians, internal medicine physicians, your next year of practice is going to markedly increase. they're all going to do very well because of this post-COVID syndrome. It's going to come up. We thought that once patient recovers, he goes off, he's okay, but now we're discovering the so-called long COVID. Of course, we know that when they affect the lungs, you can get fibrosis, and some of these patients can develop long-term interstitial lung disease like syndromes. But not only this, they're developing a variety of other lung. In fact, even incidence of obstructive airway diseases, reversible obstructive airway disease is increasing. A Japanese scientist called Ishawa actually, initially in the first wave itself, looked at autoimmune antibodies in these people and found that there were 84 types of autoimmune antibodies which were produced. At that time, we didn't know the significance, but now we know that many of these patients are coming out with like rheumatoid arthritis like symptoms, thyroiditis, a variety of autoimmune diseases are coming out now. And even diabetes, autoimmune diabetes are coming out. Similarly, CVS, young myocarditis, young blocks, CNS young blocks are coming. And more important is these neuropsychiatric syndromes, depression, fatigue, 20 to 30% of patients are continuing to have long-term. And this continues up to now. We have follow-up for 1 year. Now, one of the things that's connecting all these people is the gut microbiome. For me, this is of interest. We're studying this. We found that those patients who have COVID, the gut microbiome changes. Bacterioid contents are increasing, some of the other microbiome. And this gut microbiome changes is affecting the gut metabolites and giving rise to a variety of long-term syndromes in these patients. And some of them is so-called long fatigue, dementias, and so on, may be related to change in gut microbiome. And this may be a very interesting future topic. And finally, vaccine, because I think, again, a lot has been spoken by Raman. I'm going to talk only about few important clinical aspects, what patients ask, frequently ask questions. They ask which vaccine. There are 3 vaccines currently available in our country, the Covaxin, Covishield, and Sputnik. I tell them whatever vaccine is available to you, take the vaccine. The only difference is if you take Covishield and Sputnik, your one dose may protect you for a long period of time. Covaxin, 1 dose doesn't protect you immediately, so take 2 doses quickly, don't wait. Whereas with the Covishield and with the thing, you can wait. Sputnik, you can wait for the second dose, because in fact, there are now tendency to think of them as single dose vaccines. What interval? Now, with Covaxin, definitely 4 weeks, don't delay. With Covishield, now the government has gone up to for 16 weeks, indicating that may be taken as single dose vaccine. Is Sputnik 21 days. Now, we have also published this very important study, and some question has come up in this, that this study was published from our institute shows that if you have COVID and after 4 weeks or 3 weeks, if you take a single dose of any of the vaccine, Covaxin or Covishield, you'll develop very high dose of antibiotics. Single dose is sufficient. Don't waste and take a second dose. So this is what we have found. So when after COVID, if you have an infection, minimum wait 4 weeks, but now the government recommendation is 3 months. There are no contraindications, essentially, as Raman has told you. The only contraindication is pregnancy is still not clarified. Severe allergies in these patients, but children we're still not giving. Side effects are very, very minimal. To forget about it, I think this is a myth that has been propagated. And can we mix Covaxin and Covishield, mix and match? Right now, we're starting studies. Some people have by mistake taken it, and when they take it by mistake, we have found that when you mix this, your vaccine levels increases, the antibody levels. So you can mix and match. But more important than all this, even if you take the vaccine for next 3 months, COVID-appropriate behavior, masking, physical distance, and all is still important. Just to show some of our data, when the first wave occurred, we had about, in our hospital, 2,000 staff. You can see 400 and odd became positive, which is approximately 20%. In between the first and second wave, we were able to vaccinate all our staff. Everybody was vaccinated. And when the second wave occurred, we found that the second wave, only 75%, which is 3.7% got infected. Definitely showing protectivity of this vaccine, 7.8. And what we found in our data, as you can see, is that we also looked at the variants. In the first wave, all our patients had this standard wild type, Wuhan type. But the second wave, you see, most of them have this B16171 or 2, you can see. And when we looked at our vaccinated people who developed the infection, they all had this variant virus. So all the post-vaccinated infected people were with the variant virus and not with the Wuhan virus, indicating this vaccine protects partially And this partial protection is because of the new variant, and the Raman was also telling us this danger that can occur. But fortunately, it protects. None of the people went into, none of our staff were 70. All of them had only mild disease or moderate. None of them went into severe disease or had any deaths. So this is an important practical information I wanted to give you. So finally, take-home messages are: kindly classify your patients. Remember this classification, very important. Lab parameters and imaging play an ancillary role. Remdesivir, I believe, should be used in moderate severe cases. Steroids and tocilizumab, very, very selected. Be very careful. Anticoagulants used for 15 days and stop moderate severe cases. There's no role for definitive. And oxygen is very important as a supplemental role, especially in severe cases. And finally, to end, I'd like to thank MISAT and say that still, I think for us, it's mask and vaccine which is going to get out of this. And hopefully we can prevent a third wave if all of us as a society take this very seriously, mask ourselves, physically distance ourselves, and take the vaccine, and see in 3 months' time if we can vaccinate everybody. Thank you very much.
Thank you, sir, for that wonderful, clear-cut, authoritative information for all our physicians. I will come to you, sir, because Raman has to leave. I will ask him about 2-3 questions, and I will request him to.
Thank you.
Raman, are you ready? Sir? Raman, are you there, sir? Raman? Raman, sir? Dr. Raman? Sangram, you find out whether he is there, because he said he'll leave at 8 o'clock.
Yeah.
Okay. Till he comes, sir, I'll ask you some questions,
Okay.
Nageshwara.
Okay.
I'll ask some simple questions. You said dexamethasone IV. Why not IM?
That is what has been used in trials. Technically, you can give it also. There's no problem. Parenteral can be IM or IV, but most of the studies have used oral or IV. But you're absolutely right, Mugnan. You can also use it.
Because I am a teleconsultant for many COVID centers here.
Yeah.
They say that it's very difficult to get IV every day.
Exactly.
And IV line, if it is there, it is also a problem. So they're asking IM. Then I thought logically, though the guidelines don't say, logically when you are giving oral steroids, why not IV?
So you're absolutely right. The only issue is that if you're giving anticoagulants in therapeutic range in these people, when you're giving IM, sometimes IM injections, you have to be careful about hematomas and forming. Otherwise, I think you're absolutely right. You can give it.
I'll start some more basic things, sir. What about inhalation and goggling? Because inhalation also now become a controversy. Your views on inhalation and goggling?
I think the only inhalation that has been studied and has been shown in a good study is budesonide. Other inhalers have not been shown to have much use. There is some very early study coming in with an antiviral inhaler that's coming in. There is a study which is being done in London. Right now, we don't have data on that, so we don't have any evidence. Now, gargling, again, theoretically, in the first phase, we used to ask our patients to gargle with antiseptics and so on. But there's been one good study, which randomized control study, using antiseptic gargling versus no gargling, and there's no difference in the severity of the disease. So I think gargling, in my role, in my view, at least we don't have evidence. But if the patient feels happy and there's no harm in gargling, I mean, you can ask the patient to do that, And sometimes one very good study published in New England Journal actually looked at preventive aspect. In fact, this is a study, randomized control study. We looked at inhalers and gargling was nothing to show whether it prevents intra-family spread. And there's no evidence to study that this actually prevents intra-family spread. So steam inhalations and all may not be effective in preventing intra-family spread. And there is some evidence that if you do excessive steam inhalation, you can actually congest your lungs and produce potential viral infection.
Okay, sir. And then coming to the other usual, little tough questions. You said tocilizumab. What about bevacizumab? That is also available.
Bevacizumab has been used. There are some very strong proponents for that. Our experience has been very less. And as I said, my neurons are decreasing with age. So I don't want to remember too many drugs. I want to be very careful and remember a few things. What is very definitely evidence-based, I remember, there have been some studies with this drug which have shown to be efficacy. We have not used it, but if people have experience, maybe they can use this.
Because, sir, tocilizumab is not available in my town. We have got COVID hospitals. They don't have tocilizumab. So
Yeah.
the only drug available is bevacizumab. So that is available in 16 ml, 400 milligram.
Yes.
So they are asking me whether I can use it.
You're absolutely right. If tocilizumab is not available, we can use. With again, I think, as I said, we don't have RCT evidence for this. Even for tocilizumab, we don't have RCT evidence, but we have good observational studies with tocilizumab. And again, we use very, very less tocilizumab. In fact, I don't know why it went out of circulation, because the use, I thought, is come down now. And now it's easily available because after this mucormycosis phenomena came in, people got frightened. Now they started using it very less. So I think it will be available, but I think we should discourage our colleagues from any of these drugs because evidence-based is very less for this.
Because, I am a teleconsultant because with the knowledge gained from so many people like you. When I told the COVID hospital people who are using, really treating COVID, I asked them to stop. At least they say it is not available. And regarding the baricitinib, it should be given with remdesivir, or it can be given JAK2 inhibitors without
no. Yes,
remdesivir.
That's again a very good question. Baricitinib, I think, in my opinion, is an extremely safe drug compared to all these highly immunosuppressive drugs like steroid and tocilizumab. Baricitinib can be given, it's given orally 4 milligrams. It has to be always combined with remdesivir. So baricitinib should be given usually in the second week. It's a JAK1 and JAK2 inhibitor. It has to be given combined with remdesivir. It can also be combined with remdesivir, dexamethasone, and baricitinib. Those who are not responding to remdesivir and dexamethasone, you can add baricitinib. It's a relatively safe drug, and the important thing is the cost has come down dramatically because Indian producers are making it.
Sir, oral anticoagulants, you don't advocate. Aspirin?
Yes. So again, this is a very good question because a lot of people ask aspirin and clopidogrel because many of them are already taking it at a certain age. So if they're taking aspirin, clopidogrel, they can continue. But because what happens is here in these patients, it's mainly venous thromboembolism which is very important. And we know that aspirin and clopidogrel do not prevent venous thromboembolism. They would, of course, be acting more on arterial thromboembolism. So there's no harm if they're already taking to continue this. Now, why not oral anticoagulants? Again, it's very common practice to use, for example, apixaban is used in almost all the patients. Again, evidence in data is that we have against low molecular weight heparin, which is shown to have both anti-inflammatory, anti-fibrotic effect and mild antiviral effect. So it's been on that, and we know that we use preventive, prophylactic, and therapeutic doses. Now, can we use oral anticoagulants? You can if you don't want to give, because most of these patients are hospitalized, and therefore it's easy to give low molecular weight heparin. That's the reason why we use that. But if the patient is not hospitalized, you can use oral anticoagulants. Only thing is we don't have a scientific rationale to use this. But you can use it. There's no harm. The advantage is the recent NOAC and DOACs, you don't have to monitor the prothrombin time. That's the advantage.
But after discharge from the hospital,
yes,
after the heparin, low molecular heparin, do you advise any oral anticoagulants or aspirin in your cases?
Yeah, so again, very important. This is something which is done frequently, should not be done. After hospitalization, after they're discharged, unless you discharge them for some reason very quickly, if they're hospitalized, especially severe cases or those in the ICU, stay for at least 14 days. And most of these drugs like steroids and anticoagulants should be used for 14 days and no need of tapering. Steroids also no need of tapering, you can stop them. But for some reason, if they're discharged earlier, we can continue this, but again for 14 days, not too much time. I don't want these drugs to be continued beyond 4 weeks because that's where all the problems comes beyond 4 weeks.
I'm the person who always request you to do something on gut microbiota.
Yes.
Again, the question, you said gut microbiota future. Why not we give gut microbiota for all patients with COVID?
Yeah, I think this is a very, very good question. Now, this is, in fact, there's my group of very close friends of ours in Hong Kong who are world authorities on gut microbiome. We are actually collaborating with them. They have not only studied this very extensively in a large number of patients, but what they did was they have actually now made a pill of a gut microbiome which is beneficial in patients with COVID, and they're starting to use. They started the study. We told them if it is successful to give us the first batch. And ultimately, it looks like that fecal FMT, fecal microbiome transplantation may become one aspect of treatment. But ethical committees haven't allowed this now. But if you take one species of microbiome which is going to be useful, their study seems to suggest that it's, in fact, Hong Kong government has immediately patented it, and they are starting to use this. But it's a very good observation that you made.
Sir, because I get many patients who are IBS patients developing COVID. You know, IBS, the COVID, when you get, they're anxious, they have all problems. They get, IBS exaggerated. So in those cases, we are forced to give gut microbiota. So I thought routinely whether it will be useful, especially GI problems, predominant COVID. What do you suggest?
This is important. Now, if you're talking about probiotics in these patients, we don't, probiotic again, there are no studies, but we are little worried about giving probiotics because these patients, I didn't want to delve into the gastrointestinal syndromes in these patients because we have a lot of data now. In fact, we have published a large series of what GI symptoms occur in these patients. And one of the things that we found is that ischemic problems of the gut can occur in these patients. And ischemic problems of the gut, when they occur, they come with severe abdominal pain. And sometimes they found thrombosis of superior mesenteric artery or a partial thrombosis of inferior mesenteric and so on. We have found this in some group of these patients. So we are frightened that probiotics can actually increase it because it has been shown that probiotics can produce ischemia to the gut. So if you advocate probiotics, it's very easy to give this. All the practitioners will start, and some of these patients can suffer with gut ischemia because of this. That's the reason why we are keeping it totally out. Although, as you suggested, initially we considered it. So some groups are working on this. But once we found this ischemic phenomena, we stopped probiotics completely.
And you said the virus can spread through motion. Do you have any study whether the motion has the virus till how many days? 1 month, 2 months, 3 months, 4 months?
Yes, very, very good question again. Very important question. And we have again worked on this along with CCMB here. We found that even after the virus goes off from usually by 14th day, virus disappears from the throat. In the stool, the virus is continuing up to 28 days, so double the time. In 50% of the patients in whom the virus goes off from the throat, the virus continues in the stool, 50%. Now, whether this is responsible for fecal-oral transmission, we are not sure. But the sewage studies taken from sewage have shown that the virus is persistent in the sewage. So it can. And one other thing supporting this is that these have been very good studies done in rhesus monkey, that if you put a rice cube in the monkey and push the virus into the stomach, nowhere in the respiratory tract, in the stomach directly, it goes in the stomach and produces classic COVID syndrome of lung infection and so on. So if the virus goes into the small intestine, lung, and the stomach and small intestine also, it can produce classic COVID syndrome, need not go from the upper respiratory tract infection. So there is a pause. Why I'm saying this is that I have found many patients who come to us and tell us, look, I have not got any, I have not gone out of my home. I have not got any exposure from anybody who had COVID. I have stuck to my house for the last 15 days, 20 days. Now I got this. Then I ask them, what did you eat? They say, we got food from outside. We have water, which is municipal tap water. So potentially there is some possibility that these people are getting it from that also. But again, it is very difficult to do these studies except animal studies which have been published.
Why I asked this again, because when a husband and wife, husband is COVID positive, the wife started using the toilet. So, we'll have to observe that COVID protocol, behavior.
Exactly.
That's why I asked that.
No, that is very important because we know that from the stool, there's a spray of the virus. This has been demonstrated. In fact, tests have been done. After the stool, when they flush the toilet, the virus sprays out. And that's why you have to always close the toilet seat before flushing the virus in these patients. It could spread from one family member to other, even when they don't have contact because they're sharing the same toilet.
Is there any role for immunoglobulin?
Standard immunoglobulin, no role at all, no studies, only for monoclonal antibodies.
Sir, now you are talking about second wave. Do you think third wave also, because somebody said I'm looking forward to third wave. So what do you say?
So I think
Shankar over enthusiastically said, I'm looking forward to third wave.
Yeah. I noticed that. I think third wave, only astrologer, somebody who can read the palms of the hand can tell us whether third wave will occur or not. It requires, I think, skills in astrology. But I think this is it depends upon our behavior. If you are in the next 3 months, if you are able to vaccinate all our population, that is giving it a dose of 1 crore per day, 75 lakhs to 1 crore per day for 3 months, I can assure you, and COVID appropriate behavior, that we won't have third wave. This is definite. The problem, of course, is availability of vaccine and so on, and inappropriate COVID behavior. If this continues, we will have a third wave, but I think it will be a milder third wave. Because if herd immunity comes in, if significant number of people already are already immune, which is happening. In fact, we don't realize this, but 30-40% seems to be developing antibodies. If this happens, then we'll have a mild. If you look historically what happened, and look at what is Spanish flu, the first wave, second wave very high, third wave very mild, fourth wave very, very mild. So this can happen if you don't vaccinate. You get the same historical flow that happened with Spanish.
You said in your classification, mild, moderate, severe. And then before that, you said pre-symptomatic, asymptomatic.
Yes, yes.
How do you approach and how do you prevent them? Because asymptomatic and pre-symptomatic are the people who are definitely spreading the disease.
Yes. So these are difficult to catch. These are usually caught on contact tracing. In contact tracing, we find when you test them, or some people are anxious, they want to test because somebody in the house has it, we call. So those people, right now, one of the problems, I think this Raman would be a better person to say that if we look at epidemiological studies, one of the deficiencies in our country has been contact tracing and vigorous testing. If you do contact tracing, vigorous testing, and co-localization of these people, then it doesn't spread. But now it has gone such extent into the community that this strategy may not work. So if you by chance, if somebody has tested, found to be there, we know that he has to be isolated and so on. The problem comes not here. Problem comes for all of us. People are coming to our OPDs. We say, okay, no fever, no nothing. Maybe he's okay. But people, attendants, many of them are asymptomatic carrying this virus. They have a tendency to spread to others in crowded places, especially in the hospitals and so on. This is the problem that's going to occur. So if we are going to have universal masking and physical distancing, it doesn't matter because we know that asymptomatic people have a low amount of virus. The CT threshold, that is the cycle threshold, is very low. Spread is very less if they are masked and we are masked. So potentially, if somebody is having asymptomatic carrier state, if we wear a mask, if he is wearing a mask, if our contact time is less than 15 minutes, the chance of this virus coming to us is very, very low. So that's the way of doing it.
The second way, most of the patients develop nasal drip and URI continuing for 4 weeks, something like that. Though the nasal stuffiness is not there, their voice is nasal twang, and they always feel the sputum is coming, post-nasal drip is coming. This is one observation we make. What is your view on
that? So this is right. We have found this variant is producing a lot of different syndromes. I think many of them are going on for long-term oronasopharyngeal symptoms. Some of them is secondary bacterial infection, which can occur because of this virus, reducing the local immunity. The local immunity of the pharynx and all, again, is very fascinating. We don't have time to go into this. It is IgA dependent and T cell dependent. It's driven by these two things. So this IgA dependent, T cell dependent mucosal inflammation, which is shared by the lung, the oral mucosa, and the GI tract. That's why they're all connected together. They're all traveling in this direction. So this is affected, and that's why they're getting prolonged symptoms secondary to this, maybe secondary infections, and some of them are developing some sort of allergic rhinitis or sinusitis. So I think our ENT people are in good business for the next few years because of this type of syndrome. But one thing is, even if you find the virus, when you do a RT-PCR in these people after 14 days, it's not the active virus, it's just RNA particle that's present. Does not have much significance. The important thing is there's some very good studies. In fact, this is a study that our basic science is also doing now. We have found that this new mutant virus actually upgrades a receptor in the nasal mucosa, upgrades a receptor which is actually attaching to the mucormycosis. There's a GRP receptor there in the nasal mucosa, which is upgraded by this mutant virus. And that's why in the second wave, we're finding more of mucormycosis. So very interesting data coming. So a lot of things happening in the nasopharyngeal area, a lot of basic research is being happening. And I think we're going to get some more data on this. And part of this is this continuous syndrome there.
One more authoritative statement I require from you, because some people have written vaccination only produces mutant variants. What is your comment?
No, I think that is wrong. There's no evidence. Mutant variants has been shown with plasma. Plasma, definitely there is studies to show that if you give it irrationally, you can produce. But with vaccination, there's no evidence that giving, in fact, if you don't vaccinate the population rapidly, that's when the mutant, because what does the mutant variant require? A virus gets mutated if it enters a host and the host is not immunologically strong. When the host is not immunologically strong, and this has been shown especially with immunosuppressed people, this virus starts to mutate. It can play itself. And other thing is, there's a mistake. People say that this virus is very clever, it mutates and all. This virus is not clever, it's stupid. It's like any other RNA virus in the body. They're all very stupid. They randomly mutate. Very random. Lot of mutations are occurring which is not beneficial for the virus is dying. Only those which are beneficial go on. That's important to understand. Mutations are random. They're not beneficial to the virus. Many of them, 80% are non-beneficial mutations which are the virus is dying of, and only those which are beneficial virus are. So when will they become beneficial? If the host is immunosuppressed, then of course the chance of these mutations coming in is beneficial to the virus. So this is a mistake. I think we should quickly vaccinate before this mutation becomes more strong.
My last question before I go to chat box, mask. There are some myths, mask, if you don't use properly, you get mucormycosis. With the mask, you use double mask. Something about mask, and then we'll go to the chat box.
Yeah.
Advice about mask.
Yeah, again, very important question. There's a lot of myths about masks, and again, we don't have so much time to discuss on this. There's now concept of double mask also coming in, that you may have to use a double mask, especially those who are going to high-risk patients and all, because the lower part is not covered by standard mask. The important thing is to cover so no air enters through the outside part. That's the important thing. Most important, again, not to reuse the mask, especially the N95s and surgical masks have to be disposed of. They can be used only for certain 6 hours or 12 hours or whatever it is. Cloth mask has to be washed, dried outside in the sun before they're used. There's some families, the same mask is used by different people. This is a setting for mucormycosis, especially if it's moist and so on. And especially if people are sneezing into the mask, this mask contains a lot of particles. So somebody else is they're not properly washed or not under ultraviolet radiation, and they use this, they can develop. So I think mask culture has to also change.
Okay, I will ask the panelists. Dr. N.K. Singh, M. Shankar Sharma is asked what question. Zinc, vitamin C, iron, all out of race. Steroids leading to diabetes and mucor. What next?
No, I think this is an evolution process which we are learning. And I told you that we have to depend very strongly on, because as doctors, if we don't depend on very good evidence and suggest to our patients or society, other people are going to take over. They'll say that, for example, we have in Andhra Pradesh, in Nellore, a famous Ayurvedic or whatever medicine is giving. It has become so famous that 50,000 people, 1 lakh people going every day. That's because as doctors, we haven't been very focused on scientific. We also start using all sorts of medicines without scientific evidence. So we have to stick to very strict. There may be, we can limit our range of medication to very less, but those which have evidence, and then I think we can convince ourselves and the colleagues. Now, vitamin C and D, there's no harm. I mean, they don't do any of this thing. And there's vitamin D, there's some peripheral evidence that low vitamin D can benefit the virus. So you can give. And that also give it for a certain period of time. There's no harm in taking. But I think steroids are the one which has caused the most harm. Steroids are the most dangerous. I think all the dangers of this virus in our society is because of steroids.
Sir, I would like to...
Glutathione. What about glutathione? Do you advocate glutathione?
No, again, no, we don't have evidence for that, strong evidence for that. Only budesonide, we have some evidence.
Okay, N.K. Singh. Yes, N.K. Singh.
Yes, sir. Before I answer the Shankar Sharma question, already answered very well by the Dr. Nageshwar. Sir, you told that steroids are very dangerous at this point of time. But there is a school of thought, and there are some people that the second wave has brought different scenario in our country. Many young persons have died, and the usual protocol has not been successful. So at some point of time, the dexamethasone has been found to be a game changer, and it has been found now, it is very much being stressed that before the decreasing SpO2, there is something called the partial pressure of oxygen that decreases first. And why, if suppose in that case, in mild to moderate case, if your CRP is more than double, or suppose more than 5 times, and D dimer is double, and NL ratio is more than 3.5, why not to pick up such cases at this point of time and start the steroid so that we can avoid the death, we can avoid the hospitalization, and this could be a game changer. Please elaborate. All want to know about this.
Again, Dr. N.K. Singh is, of course, a very experienced practitioner and diabetologist. This is a very important point you brought out, and again, I want to discuss a little on this because regarding the role of steroids. Now, steroids, the first important thing is steroids, because we know the pathogenesis of this virus, steroids should never be used whatever the situation the first week, because first week is viremic phase. Steroids, as you say rightly, are advocated when the patient is defined as moderate or severe case if his oxygen saturations are coming down. If you look at the recovery study, very clearly they stated steroids are only useful when supplemental oxygen is necessary. Steroids are not useful when supplemental oxygen is not necessary, or if they are used early. Very clearly, but unfortunately in that study in New England Journal, they put it very small print so nobody reads that. This is very clear. So we have to use steroids, 1, in the second week, 2, when supplemental oxygen is necessary. And as you pointed out rightly, when the markers are increasing, you have a CRP which is going to 30, 40, IL-6 is increasing and all, steroids indicated. That is in the second week, number 2, there is no difference in the first wave and second wave. We have a data of about 20,000 patients in our institute who have been treated in the second wave also. We have seen, we are going to publish this data, where there is steroids have done more harm than good, especially if they're used in the first week. Now, all these people are talking about steroid use early on. Where is the evidence? If they can produce one paper or one RCT where they've shown that steroids are useful in the first week or steroids are useful in all patients in whom this thing, then I'll agree. But there's no evidence. There's not a single paper. It is just that based upon the clinical experience. I think we have to go beyond that. We use steroids. We use a lot of steroids, but steroids have to be used in this fashion. Second week, when supplemental oxygen is required, when markers are going up, the inflammatory markers are going up very high, when patient is having a lot of symptoms. In these people, definitely, but always in the second. That's my take on this. And also, the dosage, I'm seeing people using 32 milligrams of dexamethasone, which is, phenomenal. That's something. So this, I think, we have to keep the dosage and the timing and indication very strong. Again, I think we as responsible, especially senior physicians like, say, Dr. Enkesing, if we say that this is the indicated and all the people follow there, I think that's what happens. So I think we have to be very, very careful, because steroids can be a game changer only in that situation. In a regular situation, it's a game changer in the opposite way. All the problems you're seeing are coming.
Actually, sir, I wanted that you should clear to our audience. A second thing, sir, at Ranchi, we found that many cases presented with the pain abdomen and typical finding of pancreatitis. So what is your experience that this COVID presenting as a pancreatitis?
I think, again, very important point, Dr. Enkesing. In fact, we exchange a lot of common patients, myself and Dr. Enkesing from Ranchi, because he is a very busy practitioner there. And I see many together we discuss this. This is a very important point. This virus, again, I didn't delve into this because a lot of research is being done in our institute on virus and pancreas. This virus has got receptors both on the acinar cell of the pancreas and on the beta cell of the pancreas. So what we have found is, in fact, we have done a lot of in vitro cell culture studies that this virus goes in attached. So we now have a series of acute pancreatitis caused by this virus. And especially if they have an underlying smoking, alcoholism and all, the propensity is more. And those patients who already have chronic pancreatitis, this virus can produce acute and chronic pancreatitis. And when it does that, these patients have more incidence of necrosis, walled-off necrosis, and so on. So this virus has a definite effect on pancreas, although the case reported numbers are not large. Because we are specialized in gastroenterology, we see a large number of these cases. And also this virus has an effect on beta cell. We know that there are many de novo hyperglycemics coming in after this infection. And especially, of course, steroids increase it. And we know that those who are already diabetic, controls go off because this virus definitely has an effect on beta cells. So on both this, so definitely acute pancreatitis, exacerbation of acute and chronic pancreatitis can increase. And these patients have to be treated very specifically because of increases. So I think
I find one very interesting question from Dr. Meenakshi that if the steroids are given for 10 days, following the dose of methylprednisolone, what is your idea about the tapering of dose is required or not?
No, tapering of dose, when you use it for 14 days, not necessary. Tapering dose not.
Even in the
can I just come in, Dr. Singh? Yeah, can I just come in, Dr. Singh?
Yeah, please.
Yeah,
Dr. Reddy, excellent lecture, and we're always in interactions on patients. You did say that your neurons are degenerating. In that case, what do we all say about our neurons? So anyway, that was in a very lighter vein, Dr. Reddy. Excellent lecture. 2 points confuse me. when remdesivir is foo-fooed by WHO, I'm a member of the COVID expert committee in Karnataka. And we had a tremendous discussion, and we now bring it down only to 2 indications. Remdesivir in the first 10 days, remdesivir in those who are on a low flow of oxygen. While in your chart, it is in moderate disease, it is in severe disease, which is, you look to be an excellent proponent of a remdesivir, while all over the world, it is being, considered almost lower down. Even the AIMS says off-label. That tocilizumab, plasma, and remdesivir are off-label in AIMS. We took that AIMS help also for our guideline. And in Karnataka, we have put this in patients who are on a low oxygen and within 10 days only, not in severe cases at all, whereas your table says that. So just wanted Dr. Reddy about.
Very good point. Gurraj, I think that's a very good point. This is a very controversial point. In fact, our COVID group also had a lot of discussions when we had. In fact, we almost had a half-day discussion on remdesivir. Now, remdesivir, 2 things are important. First is we know, and I've shown this very clearly, that we must use it early on, before 10 days. After 10 days in ICU setting, there's no point in giving remdesivir. So it has to be used in a viremic phase earlier on. Remdesivir has to be used also when supplemental oxygen. So we don't use it in mild cases, only those on supplemental oxygen. Remdesivir with baricitinib has specifically been shown in ACT-2 study, which is a randomized control study published in New England Journal, to be much more efficacy than just using it without. That is the. Now, remdesivir and steroids, there are smaller studies, but we don't have a large randomized study. The only controversy is remdesivir with severe, that is patients having hypoxemia, severe disease. This is the only controversial area, which if you take all the things that is. Now, should we use it or not? Again, there is 2 very good studies, which have observational studies which have been published. One came in Lancet, another in infectious disease, where observational studies, not RCT, so they didn't come high evidence. It has been shown that there is definite evidence of remdesivir in this group. So we took all our data, we took a huge number of patients that were treated, and then we found that the side effect of remdesivir was mild increase in enzymes. None of the patients we had to discontinue because of the side effects. And we felt that if you try to differentiate moderate and severe cases based upon supplemental oxygen versus ventilation and all, then you'll create an artificial separation. For the clinician, it becomes different. So that's why you see remdesivir in that chart. But very often, our remdesivir is used within, we start off before the 10 days, or usually first week or 3rd day or 4th day. We give it in those who require supplemental oxygen. The only additional thing that I made, which I think a little again personal experience, is remdesivir without supplemental oxygen with severe disease. Yeah. So suppose if the patient has it. So in patients who are ventilated in ICU, 2nd, 3rd, 4th week, I don't think remdesivir is used. So our views are similar except for this small group, and I told you because of this. And I think the reaction of both National Ministry of Health and All India Institute has been an overreaction to this.
Correct.
You can have a reaction against the drug-producing side effects like steroids or tocilizumab, which I agree have got. But I think the reaction came partly because remdesivir was becoming in short supply, and this was randomly used for mild cases, for all the cases. Suddenly, patient on a ventilator, they'll ask for remdesivir, which is no use. So that reaction came. But I think as people who have gone into the subject, we understand, we know exactly where remdesivir is.
Just a continuation of N.K. Singh's question on steroids, my last question. Absolutely, excellently said. There are 2 problems with the steroids, Dr. Reddy. One, the AIMS says methylprednisolone, 1 gram or whatever, and says equivalent dose of dexamethasone or prednisolone. How many, apart from academic physicians in a medical college, know the equivalent table?
Exactly.
I think we really need to produce in every CCC also, not tertiary center, the equivalent dose of steroids. I think, sir, it will be a great service if you could please include in your book, the equivalent chart, number one question. And number 2, You know the practice of non-allopaths in India. The steroid misuse and increase in mucormycosis, in my own humble opinion, is the homeopaths, the all other non-allopaths do D-dimer and all these tests within 3 days of patients going. In place like Hubli, where you see my patients in Karnataka, North Karnataka, we have around 10 lakhs population, okay? And there are, I want to say, 50 non-allopathic doctors. They do D-dimer, everything in the early phase, put them on steroids. This is exactly what is happening throughout the country. Dr. Singh probably agrees with me.
Yeah.
Steroids are used well early in the disease. Whether is that worrying us? Because as Dr. Raman said, it is the antivirals that stimulate this virus. Like you also said, it is smart but stupid virus. It is stupid but smart virus, like you said. So just a comment on that, sir.
Yes, I think this is a very important point. That's why in the algorithm, you see, we are advising only to do all these markers after 1 week when the patient's symptoms are increasing. If the patient's symptoms are decreasing, don't even do it. Steroids, the greatest problem, I think this is the biggest harm that has been done. The recovery study, which was unnecessarily flashed in newspapers without giving the bottom line of when it should be used, saying they very clearly stated steroids are useful only if supplemental oxygen is needed, only in the 2nd week. Totally against what is being done with steroids. First, 3rd day, 4th day, they do CRP, elevated steroids done. This is the biggest harm. In fact, I have suggested to the Ministry of Health that kindly regulate steroid use. India is the only country where you can go over the counter and buy steroids, or some doctor not qualified also can write steroids. Kindly regulate, right? You are regulated, say for mucormycosis, amphotericin B, are regulated so many things. Kindly regulate steroid use. If you regulate steroid use, then people will know the severity. Otherwise, one steroid, they feel much better. They don't realize that the greatest harm in this virus is the steroid use in our country. That has to be changed. Unfortunately, it's very peculiar to our country. No guidelines are there. I have very strongly written to the Ministry of Health that they should do this. The steroid should be regulated. Otherwise, exactly what you said happens. We are also publishing in our book protocol, we have equivalent, say, 6 milligrams to 32 milligrams of medicine.
Nageshwara Reddy sir, one more question.
Yeah.
You said D-dimer.
Yeah.
Many physicians, they see D-dimer. If the D-dimer is increased, they say these are the people who are going to get thrombosis and they start heparin. So to start low molecular heparin, their marker is D-dimer.
Yes. I think D-dimer, there's a very lot of controversy. There is now more indication that D-dimer may not be a good indicator of how to start anticoagulants or how to stop, or increasing D-dimer doesn't mean that the patient is not responding. The only indication is D-dimer is very high, going up very high. Then this microthromboemboli is something that you suspect, and these patients should go for a CT, especially if they have hypoxia, for a CT angio to rule out pulmonary thromboemboli. That's where I think important.
Sir, now we will ask a rapid fire question, sir. Very simple question, simple answer, sir, from you. Eosinophilia also is poor prognosis. What is your opinion?
I'm not sure. I don't have any literature. At least I don't have any knowledge of that.
Eosinophilia is, of course,
lymphopenia we know definitely, but eosinophilia specifically, I'm not sure.
Eosinophilia is important in typhoid fever. When to change from HFNC to CPAP or BiPAP? What is the criteria?
I think this is CPAP, very little value. It's only BiPAP. HNFC is if the need for the oxygen is, say, 40 to 60 liters per minute. That's when you use HFNC. For lesser thing, of course, you're going to BiPAP. And BiPAP, the standard BiPAPs are not useful. In what we found is our intensivists complain that standard BiPAPs are not useful. They have BiPAPs in smaller ventilatory machines. They have this facility there. It's going useful, especially if your need is less than, say, 20 liters and all, you can go for that.
And if the CRP remains even high after 10 days after anti-inflammatory drug, what do you do? Should you
continue? So if CRP is high, the patient is not symptomatic, you can wait, because I've seen CRPs being elevated for a longer period. If the patient doesn't have any symptoms, we can wait. There's no problem.
Yeah. Your opinion on colchicine?
I think there's no evidence. It produces more nausea and vomiting. So we get more gastrointestinal referrals because of that.
And pregnant and lactating women advice on vaccination?
Yes. Lactating, definitely. There's evidence now, and even Indian government now has given permission because antibodies travel against the breast milk. It's useful. Pregnancy, The RNA vaccine has shown to be useful. 90,000 pregnant women have been vaccinated with mRNA vaccine. US, no side effects. There is no good data for our types of vaccine, for Covaxin, Covishield, or Sputnik. So we still don't data. Ministry also is not advising pregnant women.
How to prevent post-COVID and long COVID syndrome when the patients are treated?
Yeah, I think part of the post-COVID long-term is also neuropsychiatric symptoms. A lot of counseling and all that important. But in those patients who have more severe disease or come out of ventilator, I think lung fibrosis is something. There's a lot of new studies going on, drugs that are going on. I think it's very important to look at autoantibodies in these patients because they require a rheumatologist and that type of treatment also. I think, in my opinion, this fatigue, neuropsychiatric symptoms are going to be important, which we'll have to use the help of a counselor also.
Sir, last year a protocol was circulated by API to start steroids and low molecular heparin early in HCWs. Recovery is the route. What do you have to say?
Early in what?
Last year, the API has given us protocol where they say to start steroids and low molecular heparin early in the healthcare workers.
No, I don't think there's any evidence. In fact, whether it's healthcare worker or patient, the physiology is same in terms of virus. So we should not give steroids the first week at all. Of course, we avoid as far as possible, but it's only in the second week that steroids use comes. So early we should never use. Anticoagulants also use comes only in the second.
Sir, I will say here that API has not given such direction any time. So this is, I don't think API has ever published like this.
No, it is not from API. Dr. Singh is right. It is not from API, sir. Maybe that person asking question hasn't put it right.
Somebody asked the question.
Yeah. Harun Hussain, one young patient presented to a peripheral hospital 7 days of symptoms, features of cytokine storm, has been given bevacizumab, had no improvement and was referred to tertiary care. Symptoms were persistent. Their IL-6 still high and patient symptomatic. Relatives want to know if tocilizumab can be given.
Yeah, so again, this is an empirical situation. We have to know a lot of other parameters. What is ventilation status and all that. But certainly there is a role for tocilizumab in this type of patient.
If how long does the transaminase to decrease in post-viral illness with respect to COVID? SGOT, SGPT are increased just by 2 folds. How long does it take to decrease?
So in about 20% of the patients, we have found that SGOT, SGPT is increased. It usually takes 2 weeks to come down. But remdesivir also causes increased SGOT, SGPT, and usually that takes about a week to come down. So 1 to 2 weeks, SGOT, SGPT come down.
Sir, you said very interesting. One interesting question when you said observation. TMPRSS2 enzyme is less in India. Something like that you were saying.
Yes. So this is the TMPRSS2 is a specific enzyme which splices the S1, S2 protein. And when it slices, because the virus comes and attaches to the ACE2 receptor with S1 protein, but it can't enter into the cell. The only way it can enter the cell is S1, S2 is spliced. When S1, S2 is spliced, then the virus enters of the cell. So without TMPRSS2 enzyme, the virus cannot enter into the cell. And we found in the first, when the first wave came, when we looked at all our patients, 50% of them had a mutation at the TMPRSS1. That's the reason why we found the severity was very less. This mutant virus seems to be escaping that phenomena. We are actually studying it. Even that, our mortality rate is still low compared to Western countries in spite of the high infectivity that we have. And part of it is related to the TMPRSS2.
Yeah, that is a very
Dr. Muruganathan sir. Yeah. Muruganathan sir, Dr. Reddy has another meeting at 8:30.
Okay.
I think we have to leave.
Okay. We will leave.
With the permission of Muruganathan.
Yes, sir. Sivaraj.
Muruganathan, with permission, sir, can I ask one question, Dr. Nageshwara Reddy, sir?
Please, sir.
In Gulbarga, in Bangalore also, they are trying low dose and short course radiotherapy. Any observation from you?
No, I think it's not at all recommended, at least in literature. I don't know what's the rationale by trying it. I would not recommend it at all.
Okay. Now the last message from the panelists. Guru Satur, one message from you and NK Singh, and the last word from Nageshwara Reddy. Please, we are wind up.
And Dr. Nageshwara Reddy, it has been a tremendous pleasure listening to you. And what promptly stands out is your humility. Because even when I write personal letters to you, you see the patient yourself. I think despite busy schedule, it has been great. And I never knew that you did so much of work on COVID when your specialty is entirely 180 degrees opposite to this. So really commendable. And if you could please let us know through Dr. Sangram where we can get the soft copy of your guidelines and the book, when you have included the steroid equivalent dosage, which is extremely important even to the COVID care center, which Dr. Singh was asking the question that they are using this. So, sir, thanks a lot, and may God bless all of us.
Thank you, Guru Raj. Now, NK Singh, your final message.
Yes, sir. My final message is, sir, that the virus does not kill directly. It kills by immune inflammation. This is the thing. So we need to fight the inflammation at the very right time, and we need a cat-like observation and timely step up. That is very, very important to pick up the cases when it is going. As Dr. Reddy showed that there is now the new thing is coming up, that is the antibody, that is monoclonal antibody, but they say that can be used in the mild to moderate cases, but you need to pick up the high risk cases. So how to pick up those high risk cases is the art of treating the COVID cases. So we should more discuss, more educate our physicians to pick up those cases, and that is going to be a game changer. Thank you very much, sir.
Thank you, NK Singh. Why you say cat-like observation? It is like AIG observation or Nageshwara Reddy observation. Over to you, Nageshwara Reddy.
That will be a better.
Again,
final comment from you.
I like to thank I think Mr. and Sangram especially for giving this opportunity. It's always very nice to interact with all of you. I think every seminar we have with you. I know this is out of my subject area, gastroenterology, but again, I have to be I give the right credit to our people that most of this knowledge and the research that's being done in our institute is by so many other consultants. We have a group of very young, bright consultants who are doing a lot of research work, a lot of clinical work in this area. I just listen to them and diffuse and osmosis, I get some of this knowledge. And we have these good meetings every time updating ourselves. So most of the credit should go to them actually. And again, I'm extremely thankful for giving me this opportunity to talk to you.